Hello everyone, welcome you all to another video on surgical MCQ discussion. In this video, we will be discussing on hyperthyroidism. This is also a common topic which will be questioned from you. So we will look at the clinical features, investigations and evaluation for etiology of hyperthyroidism. Regarding the clinical features, there are symptoms and signs. There are many symptoms of hyperthyroidism. However, I have mentioned 5 main symptoms here. Those are anxiety, tremor, palpitations, heat intolerance, and weight loss despite normal or increased appetite. So it's better to remember these symptoms. These will be useful for you in theory papers and also for your clinical exams. As physical signs, we may detect the features of hyperthyroidism like tremors, increased sweating of the patient, and also patient may have rapid speech. So you may look at the short case examination video of thyroid gland and see how these physical signs are elicited. And in patients with Graves' disease, there's a set of physical signs specific to Graves' disease. Those are exophthalmos. This picture shows the eyes of a patient with exophthalmos. So there will be bulging eyes. And also the patient will have lid lag. We will ask the patient to focus on our finger while moving from upside down. Then we will be able to see that the closure of the upper lid lags behind the movements of the eye. So that is called lid lag. And also the patient may have little retraction. The upper eyelid may be retracted upwards. And ophthalmoplegia, that is limitation of extraocular movements. And also the patient may have infiltrative dermopathy, which is also called pretibial myxedema. Those are the physical signs specific for Graves' disease. Then let's look at the investigations. As initial investigations, we can do TSH level in these patients if we suspect hyperthyroidism. Obviously the TSH level will be low because the T3 and T4 is high, so it inhibits the secretion of TSH, therefore the TSH level will be low. And also we can do free T4 and T3 in these patients after doing TSH. If free T4 and T3 is high, that means the patient is having overt hyperthyroidism. If the free T4 and T3 is normal, that means the patient is having subclinical hyperthyroidism. That is how we can evaluate a patient with hyperthyroidism with hormonal assays, and also depending on the clinical picture, we can perform other investigations such as thyroid ultrasound scan and etc. So let's see how we can evaluate these patients with hyperthyroidism for an etiology. So after confirming the diagnosis of hyperthyroidism by TSH and free T4 and T3, then we can see whether this patient is having new onset ophthalmopathy. So I mentioned previously what are the clinical signs which are present in ophthalmopathy, that is exophthalmos, lid lag, lid retraction and ophthalmoplegia. If the patient is having that ophthalmopathy and also a large non-nodular thyroid, that is diffusely enlarged thyroid gland. So if the patient have these features, then the most likely diagnosis is Graves' disease. So if we look at Graves' disease, it is the most common cause of hyperthyroidism, and it is an autoimmune disorder involving TSH receptor antibodies. As you can see in this picture, like any other autoimmune disorder, the TSH receptor antibodies are produced by the B cells, which acts against the own tissues of the body, which are the thyroid tissues and the tissues around the eye. When these TSH receptor antibodies act on the thyroid tissues, that increase the production of thyroxine, so it increased the free T3 and T4 levels, and due to hypersecretion of thyroxine, the gland get hyperplastic, so it diffusely enlarged. So we will be able to see a diffusely enlarged large thyroid gland in patients with Graves' disease, and also the vascularity of the gland will be high because it is hyperfunctioning. When these TSH receptor antibodies act on the eye, it causes inflammation, infiltration, edema and fibrosis, and it will give rise to the physical signs found in Graves' ophthalmopathy. That is the pathophysiology of Graves' disease. So, if a patient presenting with hyperthyroidism has new onset ophthalmopathy and large non-nodular or diffuse thyroid gland, then the diagnosis is Graves' disease. If the patient doesn't have ophthalmopathy and also the patient doesn't have diffusely enlarged large thyroid gland, then we have to see whether the patient have a nodular goiter. If the patient have a nodular goiter, the diagnosis will be different. If the patient doesn't have nodular goiter either, the patient does not have a diffusely enlarged large thyroid gland and also the patient does not have a nodular goiter, then we can do thyrotropin receptor antibodies level in this patient. Those are the same antibodies, TSH receptor antibodies, so we can do TSH receptor antibodies, and if those antibodies are positive, then the diagnosis is Graves' disease. If those antibodies are negative, then the diagnosis can be decided based on a radioiodine uptake scan. So in those patients without ophthalmopathy and also without any diffusely enlarged large thyroid gland and also do not have a nodular goiter as well, then we can do radioiodine uptake scan because they are having hyperthyroidism. In the radioiodine uptake scan, if the uptake is high or normal, then the diagnosis may be Graves' disease, although the antibodies are negative. And also the diagnosis may be Hashimoto's as well. If the uptake is low or absent, then the diagnosis may be thyroiditis. There are several types of thyroiditis. One is Dick-Owens thyroiditis. It is chronic granulomatous thyroiditis. So there will be a viral or post-viral syndrome. So the patient will have fever and malaise and also painful and tender goiter. So if a patient is having fever, malaise and neck swelling, which is a thyroid swelling, which is painful and tender, then the diagnosis of Dick-Owens thyroiditis is highly likely. And also it may be drug-induced thyroiditis. A common drug involved is amiodarone. And radiation thyroiditis is also a possibility. After exposure to radiation, maybe radiotherapy, these patients may get thyroiditis. And also Riedel's thyroiditis which is chronic, and the patient will have stone-like non-tender thyroid gland. So if a patient is having stone-like non-tender thyroid gland, then we have to think about Riedel's thyroiditis as well. And also in those patients who are having low or absent radioiodine uptake, then the diagnosis may be an extrathyroidal source of thyroxine secretion as well. So that is how we can evaluate a patient who is having hyperthyroidism, and also the patient did not have ophthalmopathy and also did not have a diffusely enlarged large goiter, and then we did thyrotropin antibodies level which became negative. So then the possible diagnoses are thyroiditis and extrathyroidal source of thyroxine secretion. So assume that in a patient who presents with hyperthyroidism and the patient doesn't have ophthalmopathy or diffusely enlarged large goiter, but the patient has a nodular goiter. So a nodular goiter with hyperthyroidism, to come to a diagnosis, we can do radioiodine uptake scan. If the uptake is low or absent, then the diagnosis may be iodine-induced thyroiditis, which is a rare condition, occurs after a large dose of iodine. If the uptake is high or normal, then it may be toxic multinodular goiter, and also it may be a toxic adenoma. Like that, we can evaluate patients with hyperthyroidism. So you need to have a basic idea about how to identify these patients and come to an etiological diagnosis. So we discussed about the clinical features of hyperthyroidism, the basic investigations, the hormonal assays, and how we can evaluate for an etiology. So let's look at few questions to see how these can be asked in your exam. Here is a single best answer type question. A 20-year-old girl presented with excessive sweating, palpitations and anxiety. So excessive sweating, palpitations, anxiety are symptoms of hyperthyroidism. So we may assume that this patient may be having hyperthyroidism. So on examination, there's diffuse goiter and tremors, and lid-lag and periorbital edema. So lid-lag and periorbital edema causing ophthalmos and lid retraction. So those are the features of Graves' ophthalmopathy. So when a patient with hyperthyroidism is having diffusely enlarged large goiter with ophthalmopathy, then the diagnosis is Graves' disease, as we mentioned in the video. So the correct answer here is Graves' disease. So you know that the answer toxic adenoma is false because it gives nodular goiter, not diffuse enlargement. Dick vein thyroiditis, it causes hypothyroidism. These patients have features like post-viral or viral syndrome with fever, malaise, painful and tender goiter, and those patients do not have the features of Graves' ophthalmopathy. And toxic multinodular goiter also causes nodular enlargement of the thyroid gland, and Hashimoto's thyroiditis is also out because it does not cause ophthalmopathy. So if you are clear about the theory regarding hyperthyroidism, then you can easily answer these questions. This is another question. An 18-year-old female has diffuse enlargement of thyroid gland confirmed by ultrasonography. What is the most appropriate next investigation? So this question is not directly related to hyperthyroidism, but when the thyroid gland is diffusely enlarged, there are a few diagnoses. One is Graves' disease, and also it may be thyroiditis. So in either cases, it causes either hyperthyroidism or hypothyroidism. So when a patient presents with diffusely enlarged thyroid gland, it is better to do TSH level initially. Then based on that, we can do further investigations to assess for the etiology. So the correct answer here would be TSH. And based on TSH level, we can perform the other investigations. That is how the questions will be asked in your exam. So be clear about this knowledge, then you can answer the questions easily.